next talk, which is something very interesting, the Bimatoprost implant, which Michael COOTE from Melbourne is going to tell us about.
It's amazing to have standing room only in a glaucoma session. Do you want to have a moment, see if you can find another seat or move? Are you okay over there? All right, we shall continue then. Sorry, I'll go back on that. Yes, that's right.
Yeah, do you want to come in front?
Anybody who wants to come and sit in the front?
Front.
So, or maybe on the aisles? Yeah.
We can't turn away people from a glaucoma session. That's something wrong with that.
Yeah, you can please come.
The youngsters can come in the front, please.
That's right. Maybe if the speakers come up.
Alex,
Why don't you bring the speakers up?
Professor Arthur, please. Please. Yeah. Yes.
I feel like I've derailed your session now, Benny. I'm sorry about that.
Yes.
We don't have enough chairs.
It's a good problem to have, though, isn't it?
Yeah, Vinesh, you said that we need a bigger room.
Yeah. It's because of Alex. That's right. So we're talking a lot about drugs and new drugs, but old drugs delivered differently matter as well. And this is in line with essentially all of medicine. The idea of targeting a medicine to exactly the space that it's needed, that is one way of preventing side effects. So one of the things that we know, of course, is that drops are a very inefficient way of delivering medicine to the anterior chamber. In fact, I've been in practice 30 years and it still surprises me that drops ever get into the front of the eye at all, but obviously they do. But we deliver a large amount more than is needed. A lot of people don't administer them very well. Many people, in fact, even miss the eye when they're observed. A lot of the bottles are contaminated. There's all sorts of different problems with them. We all know these. There's also a poor adherence rate. Some of this is from US data where there's almost a disincentive, and where in Australia we're probably a little bit better, but in fact this is fairly common over the whole world. There is quite a significant reduction in how many medicines are taken over time. And unfortunately that does have a corollary to the effect of treatment. So if you look at people progressing, the number of medicines that are missed is definitely related to that. One of the most common starting medicines is prostaglandin, and of course a lot of prostaglandins produce conjunctival hyperemia. We're listening to a fantastic talk by Arthur, and I'm wondering really whether or not the hyperemia ends up being partly defeating of their effect. But it also produces orbital effects and lid effects, and they seem to have perhaps a genetic predisposition, but having said that, it can be very pronounced in a lot of people. So the idea of using perhaps a sustained release agent inside the eye has been an attraction for some time, and there are now 3 of these that are in advanced stage or commercially available at least someplace in the world. Just a note though, that in dogs using some data from AbbVie, there is a large amount of prostaglandin that goes into the orbit and goes into lids, and if you biopsy the tissue around an eye, you found really quite significant doses, in fact significantly higher doses than's in the eye, which is a bit disappointing. Of course you can tell the eye that's having the prostaglandin in this picture, and it becomes quite noticeable when it's put in one eye. So there are 3 front runners in this space. One of them is AbbVie's Bimatoprost SR, which is a so-called Durista. There's a polyactiva product which is from Australia, and I'll talk to you a little bit about that. And then there's the Glaukos iDose TR. They're all effectively prostaglandin release. There's a little movie from AbbVie. It's actually not unlike that when you do it. It's a relatively straightforward process. It sits in the inferior angle. It is a opaque, white, small object which is quite visible and sometimes is adherent to the iris before it makes it to the angle. It's designed to last for about 4 months, or at least 4 months. It's actually a little bit difficult to know sometimes when it does stop working because the implant is still visible even after it seems to have lost. It has 10 micrograms in a basically bioerodible kind of container. But you know, the sobering component of this is that in one of these agents, there is only the amount of medicine that is in one drop of drop that you put in it lasts 4 months. So the amount of overkill we're having with topical medication is quite extraordinary. That's the size of it, which is very small. Now I've used quite a few of these in a study, and they do work. They're nice. They, when they're piled on top of each other, so if you use more than one, you do run an increasing risk of accumulation of prostaglandin locally, and there is some inflammatory sequelae from that, and there has been some endothelial changes which are mostly reversible. Over a period of time, they become that kind of honeycomb structure on the right-hand side of your screen, and then there's probably no drug left in them. That's essentially the process of change over time. They swell to start with and then shrink, but you can usually see them even many years afterwards. The polyactiva uses a very different chemistry. The chemistry is really quite interesting, and in fact a very clever chemist worked this out, that you can stitch things together using these biodegradation components that allow you to slow or speed up the rate of degradation. And again, really small amounts of drug are needed, but you can structure this, and now you can put them into this now completely clear structure, which is implanted in a very similar way. In fact, the video for the Durista would be pretty much the same. It's very hard to see. It can be a bit frustrating. I was just talking to Sanjay before. It can be a little bit frustrating when you put them in because you can't actually see them, and they're not visible on ACT, but they do disintegrate completely, and there's no residue. There's not been the inflammatory components, potentially probably because it's a slightly larger size, and the material that is the sort of degrading components of it don't seem to be inflammatory. They work well. This data would be pretty much the same as Durista. You're getting good long-term use. They're building currently one that will work for a year, and there's good reason to believe it will work for a year. So you'll be able to give a single injection into the eye which will last a year. This technology is remarkably stable, and when we were doing some of the preliminary studies, they said that it would degrade in 26 weeks, and you think, well, that's kind of a little bit of nonsense, but it actually degrades in 24 to 27 weeks in everyone, so it's quite an extraordinary technology. A lot of good data, but again, very similar to all the others that are around. Finally, of course, there is the Glaukos AIOS2025, which is a kind of very different device, and I'll show you the video of that. This is courtesy of Glaukos, but it's certainly much more an operative intervention. This can't be done in the office. The others can be done in the office. And it has this proprietary release system and a form of travoprost, which is not used as a drop. It's in an oil form with a membrane. Now, those of you who've used eye stents, it's obviously a very similar process to that. There is a bit of bleeding, and presumably you could get a little bit more on occasion as well. The results are encouraging, there's no doubt about that. This is probably a more sophisticated release system. The intent is that this will last up to 3 years, so it's quite now a sustained release, but over a long period of time. I think there are challenges, I think, to get the predictability over that length of time. So certainly at 2 years, you're seeing it. They are measuring anterior chamber concentrations of travoprost and the free acid, which is the active component of it, and there are good endpoints up to 24 months, so it's quite encouraging in that regard. Having said all of that, there are a lot of controversies about all this, and the first one, of course, is just the value of it. These are expensive products, often far in excess of that which would be in the domain of the drops, even if they were the latest and greatest drops. There's no doubt that if you got increased compliance, if you got all of the things that are puted as value for someone who was unable to use drops before and the alternate was an operation, then it would have cost effectiveness. But I think if you were saying just to do this for someone who was reasonably efficient at using drops, I think the cost effectiveness would be a challenge to make. There is some safety issues, anything that stays in your eye for a length of time, and so the complete absorption of the LATA, the polyactiva device, is a kind of reassurance. The non-absorption of the Bimatoprost completely is a tricky one because you can't quite tell whether it's still releasing drug, and we've got no long-term issues associated with the metal insert part of the eye dose, but one assumes that could possibly give issues. There is endothelial loss that's occurred because of multiple doses of Durista, usually focal, but it's an inflammatory process almost certainly. The length of efficacy, of course, one of the whole things about this is that you could give this to someone, they could go away and then not come back. But if there was some variation in the length of efficacy, that would be a big issue. So you would not be able to determine that easily. And so once you're getting out to things like 2 years, if there was significant variation after that, you may end up giving reassurance to patients, which was not appropriate. So the variability of effect as well is something we've seen people in whom we've put these in and haven't had a terrific effect, and other people where it's been very profound. And then there's a prolonged effect afterwards, which has been called pharmacosurgery. So the idea that you get this continued effect even after the prostaglandin is gone. I can see Alex moving his head up and down, but whether that exists or not, I'm unclear. So perhaps Alex, you can comment on that later.
Sure.
And then there may be this conversation that we're also having about the decrease in episcleral venous pressure, which is really just about the side effect of the prostaglandins on the surface. And this is a Mike Robinson view. I'm not sure whether or not it's supported by anyone else. Of course, this person was in a trial, and you could see that after 6 months, you can quite see the eye that was in fact treated. So you don't get prostaglandin side effects into the orbit, so it's quite a profound effect. The future is bright. Thank you.
Any question? You can,
Yes.
the mic is
All right.
here.
Mic
Right
is in
there.
the center.
A lovely talk, sir, Dr. Coote. My questions are a few. These can be implanted even in a narrow angle glaucoma, in the angle?
Yes,
have
they're
you done
not
that?
currently meant to be, any
Yeah.
of them.
Yeah.
We have put them in reasonably narrow people.
Okay.
And somewhat, just because of set of circumstances, we have had one that actually touched the endothelium until it absorbed, and it didn't cause any particular issues.
Okay.
It's still a matter of a little bit of controversy. There's no doubt the people at AbbVie think that the contact is a problem. I have to say my personal view is that I don't think it's that. I think it's a toxicity issue if you get it. So, yes, you can, but they're a bit more designed with this space. Yeah.
Okay. What is the post-op regimen that you use when you put in the implant?
Well, it's-
And for how many days? Are you using topical steroids to prevent inflammation? Or are you
No.
using topical antibiotics because
No.
it's an intraocular procedure?
Well, no to both of those. I
No to-
might get some pushback from the audience. We do it the same as you would do an intravitreal injection, which is that topical antibiotics afterwards, prophylactic, are a bit of a problem. The microbiologists don't really
But no
agree with that.
low potency steroids required, no inflammation seen.
No, you don't get any inflammation really. You don't touch anything, so it goes through clear cornea.
Okay.
Yeah.
And you're not filling the chamber with a viscoelastic, you're just going and injecting.
Well, it depends on which one. The iodose does.
The
require
first
that.
one?
Yeah, both of the first two.
Yeah.
No, they're just done in the chair.
Okay.
In the office.
And it dissolves after 3 months, or it remains there and you put in another pellet?
The
Where
latter
when you have
one.
to reintroduce, have you reintroduced also?
Yes,
in a
we've
second?
done in both of those
So
ones on the
Does
trial
the
basis.
pellet remain inside or it dissolves?
The Durista remains visible, but
Okay.
it probably has no drug left in it, whereas the latter, the second one, remains completely, it goes entirely.
And post-op, do you ask the patient to be propped up for a day or two so that it settles in the lower angle, or with the
No.
movement of the
No.
patient, does it move to the angles and to
It
the
does
sides?
that, you aim it towards the inferior angle and it generally lands there pretty quickly.
And it sticks there? How does it
Yeah, they're both
remain
mildly
there?
adherent to iris, so they tend to stick to iris. They're intended to do so.
And the adhesion comes after how many days?
Well, it probably comes after
Suppose the
hours.
patient wants to sleep on his tummy or has a habit, do you give some kind of
Well-
post-op instructions?
These are all very good questions. In a trial, we wanted to be able to see it, so we did give those instructions. But in real life, it wouldn't matter. You could put it behind the iris, so you don't have to observe it. So I think it was only in the trial circumstance where we gave that
And
instruction.
in the last implant, the last question, in the last implant in the AIOS, which you're saying is effective for about 3 years, then
That's the intent,
when you
yeah.
put in another implant, would you like to take out the other one?
I don't know they've got to that point yet. So,
Okay.
yeah.
And the intra bleeding that you had, would it obstruct the mechanism of diffusion of that by fibrosis?
I do confess that's not my video,
Okay.
so I'm not sure about it, but it could be an issue, sure.
Thank you.
Yeah.
I can make a couple comments to your questions. I've done both clinically and not in studies. iDose is a surgery, so you're giving antibiotics, your viscoelastic of the eye, all that kind of stuff. The Durista stuff is not surgery. I also treat it like an intravitreal injection. And you ask the patient to make sure that they're upright for the rest of the day. So they don't need to, like, it's not like a very, very long time. The pharmacosurgery thing is interesting. So I like mysteries. When I have my talk, it's about mysteries. I like mysteries. So the mystery is this. As Michael was saying, on the AbbVie side with Durista, it's very clear that the drug is gone in 3 months. Glaukos is also saying, because they're measuring drug, that the drug is gone in a couple years. Clinically, I've done both. I don't have 3-year experience, but I have with Durista 1-year experience where the effect lasts for almost a year, but it's slowly going away. And Glaukos is saying the same thing, that after 2 years, the effect is dragging on. So when clearly there's no more medicine left. So there is some kind of modeling long-term change to the eye, which could be beneficial. And that's a mystery that I think needs to be explored.
Any questions?
Supposing the patient is like, sleeping is a different thing. Beautiful talk, by the way. The sleeping is a different thing, but the patient is walking or maybe running to catch a train or something. With the eye movements, would these implants move?
I may end up disagreeing with Ali. I don't think it matters where it lands in the eye. For study purposes, it's nice to be able to see it. But I think Mike Robbins and I were talking about putting it actually behind the iris.
Yes.
So in phakic eyes, it doesn't cause cataract?
No. They're tiny things. They're almost isodense. They do fall with gravity, but only just. It's just nice to be able to see it, that's all. If you want to see it, you put it in front of them.
Great, thanks for a very nice talk. My question is this currently approved for use in Australia, and how much does it cost there? I ask.
No, it's
okay.
not approved for use.
Yeah, I ask because in the United States, it's approved. The device alone costs somewhere between $10,000 to $14,000, which sets some sort of record for least cost-effective treatment.
You mean iDose, not Durista?
iDose,
Yes.
that's correct, iDose.
No, Durista is much cheaper than that.
Right. And so I bring this up because obviously we're in a country where glaucoma care is much more cost-effective. But this is a major concern, and it'd be interesting to see in a different country how they determine the value of this device.
I think if you, the short answer is it wouldn't get across the line.
One last question if we have time. I was interested, with all the intraocular implants, drug delivery platforms, what happens if the aqueous composition is not, ideal? Let's say if you have uveitic glaucomas, or if you have some kind of plasmoid aqueous, or the aqueous composition and the function is not normal. So how does the pharmacokinetics of that implant change? And how does that impact the intraocular?
It's a great question. The inventor did do a little bit of that, but only ex vivo. The answer is it doesn't seem to matter. The level of protein, at least for the latter, doesn't alter it. It's essentially an aqueous process, and as long as it's still 95% water, it doesn't seem to make a difference. It does matter on temperature, though, but I don't think your anterior chamber varies enough for that. But I think if you got down to very low levels.
Thanks, Michael.